This is Mason with Live Oak. We're going to talk about various mental health topics, how to be in control of your mental health. I'm going to do an interview with Dr. Goodwin. I actually met Dr. Goodwin at a nurse practitioner conference, and we sat and hang out for a day and a half, and then all of a sudden I looked over and he's gone and he's the next speaker. And so he was able to teach us about mental health at that time. I learned a lot about lithium. So hope you enjoy, and hopefully you can help you in your own mental health journey with this info. I'm here with Dr. Goodwin. He is a psychiatric mental health nurse practitioner. I kind of wanted to just get into mental health just for patients, as it's a tough topic to discuss, people to go over. Can you just give me a brief background about you and your history and your education and everything?
Oh, yeah, sure. What's up? Yeah, I am a psychiatric nurse practitioner. I have been practicing for like 5 or 6 years as a psychiatric nurse practitioner. And before that, I was a psychiatric RN for like 11 or 12 years since like 2012. And I also taught psychiatric nursing for a while. I've been running a private practice for the last 6 years, doing pretty traditional psychiatric like psychiatry, like medication management. I have sort of periods of time tried to focus on things like functional sort of psychiatry. That was really in the beginning of me practicing, where I was like, I'm really going to this is going to be my focus. And kind of, I think I've maybe done a good job, or maybe have had to sort of respond to the needs of my area, and that sort of, I think a lot of people really respected that I wanted to be more functional minded, but sort of the needs overwhelmed that a lot of people were just looking for basic psych services. And there's a period of time that I got really into hormones and got like hormone trained. And now, while still doing a lot of mainstream psych, I also do ketamine and esketamine and TMS, which sort of found a way to sort of have a functional sort of alternative approach to psychiatry, while also still being fully mainstream, insurance covered, but giving people a good alternative to mental health. And I think that's less out of a criticism of mainstream psych, but more so out of a people needing alternatives, because there's just so much limitation to psychiatric treatment, and there's so much complexity to mental health. So that's kind of where I live, but there's so many facets to it. And I think that lifestyle is so important. And I think hormones is such an overlooked component of mental health that I'm happy to talk to you about that. I think I'm excited to talk to you about that. Because
when you say functional psych, what do you mean by that? Like, what does that entail from a functional perspective?
Yeah, I have no idea. I worked on a course, the Elite Nurse Practitioner, and they wanted me to do a functional course, and I love that. It has all the meanings and no meaning. I've studied like a functional, or like integrative, or like, I think I told someone, yeah, I'm really into integrative, and then they're like, oh, great, and then they told me all this stuff, and like, oh, they have a completely different meaning than I do. So I think it's sort of, I think that everyone kind of has their own meanings, but it's like, I think it's sort of a way to say, lifestyle, maybe dietary supplements, alternatives, and then sometimes when the rubber meets the road, it's like, oh, we're just talking about supplements, right? Ultimately, at the end of the day, we're talking about 17 supplements that I'm taking to avoid taking Prozac. So that's, that's kind of what I mean. But really functional is, all the things that do sort of get slept on that can be just as effective, or maybe the reasons why psych meds aren't effective, or often aren't effective, is because are getting slept on.
Right. So I think that's great. And I kind of want to, just start as the lifestyle. What lifestyle factors do you think are best to have good control of your mental health, to assess your mental health, or how do I even consider lifestyle factors to improve my mental health?
Yeah. And if you just kind of where you're starting, and a lot of the people that I'm working with are starting at a place where they're already sort of debilitated. And that becomes really discouraging to talk to them about. There's sort of this idea of like, oh, I know that I should be doing X, Y, and Z. I know that I should be exercising. I know that I should be eating. And they sort of know that the cycle feeds itself. I'm feeling depressed. So I don't exercise. So I feel depressed. Right. Whereas people who maybe have sort of, they know that they aren't functioning at 100%, maybe have more are more capable of making some changes where they can just be more functional. But I think for starting for the people who are already debilitated, you sort of want you sort of you want to bring things up that are as doable as possible. And so, you know, exercising, 3 times a week, what I mean? Like making, eating at all versus not eating, you know what I mean? Or making good. So things like that can make a huge difference. Just sort of looking at where the deficits are can play a big role. Where then, people who are able to make more and more precise decisions, exercising regularly or making good dietary decisions are always the better and better you do, the more mentally healthy you're going to be. I think it plays a direct role with exercise and
Are there,
diet and
yeah, as one that like, maybe to help prevent from getting to the debilitated stage, are there any like subtle signs of anxiety and depression that, maybe the normal person doesn't even pick up themselves, but you would pick up in a normal thing? And can you address them at an early stage like that rather than waiting and they brew and then it's more difficult to treat at that time?
yeah, maybe it's not necessarily a world that I live in. I mean, I don't necessarily see it as much in
Gotcha.
the people who
Yeah.
are coming to me. You know what I mean? So I think so. And maybe that's what what I mean. I think and maybe the sign. I mean, I think maybe a healthier person's already doing stuff like that. So maybe the sign is that already. Like the sign is that I'm already not taking care of myself a little bit. I'm already not exercising. I'm already not. I'm already not eating the things that I should be or something like that. And so those are the signs that it's starting to slip, and I'm becoming that's what I would think. But
All right. Yeah. So something, and this is kind of a little bit of ignorance on my part, but I will frequently, recommend counseling to somebody. Um, just like I can kind of pick up that they're struggling a little bit and trying to be sensitive about the topic. And I'll recommend, maybe consider counseling or something. But when would I recommend counseling rather than just like, hey, I need to put in a referral to see somebody like you or a psychiatrist? Should I just do both?
oh yeah. I think I think counseling is a good thing for a lot of people. You know what I mean? I don't think I think that people who are wanting to better themselves or improve themselves, I think a lot of people who have their stuff together are regularly getting therapy. So I think it just depends on your, how you view therapy, if it's an intervention or if it's sort of a maintenance thing. And a lot of people who work with their therapists have worked with their therapist for a long, long time. And some therapists think of it as like, yeah, the goal is for you not to need me anymore. And some people look at it as, I'm always going to need a therapist. And so I don't think there's anything wrong with either approach. But I think it just depends on the values of the person you're talking to and where you're at. Do they think that they could benefit from a therapist? Do you think they could benefit from a therapist? And it seems like a good intervention if you're seeing like, okay, maybe this person could really use that. Where I'm looking at, you know what I mean? I think that could definitely be an earlier intervention than psychiatry for sure. And I think it should be, you know what I mean? I think it definitely should be trying therapy before meds, especially if the symptoms are not like severe or not moderate as far as depression, anxiety. Like they can tell they're struggling, they're not at 100%. They can still work full time. They're not on the verge of divorce, but they're like, they're not living their life they really think they should be living. Therapy is a great option for sure.
And is there a specific threshold or anything? I mean, you kind of touched on it a little bit, but like whenever, hey, therapy's not getting everything that we need out of it, you need to see, a psychiatric provider to discuss meds and further interventions. Is there an easy way to do that, or is it just really person dependent?
Yeah, I think it's perspective. But what I see a lot of times people is they'll do therapy and they'll be in therapy for like 9 months or whatever. And then it's sort of like they learn the different ways, the different consequences of what's happened. And they're like, oh, I didn't realize that this has been happening like this. Or I didn't realize, because a lot of times the depression and the anxiety are just subjective, right? And a lot of times maybe the people around them are nervous about bringing it up to them. They're sort of observable. And so as we become more and more self-aware, they're like, oh, I didn't realize how much I really was struggling with this, or oh, I didn't realize how much my relationships have suffered, or I didn't realize that, oh, my boss has been dropping hints that they're ready to let me go. So the consequences sort of become more and more prevalent, or you know, there sort of becomes, they sort of get better a little bit, and then they realize all the things they're missing, and so then and so and then they can't, maybe they get to a certain point where they're not improving anymore, or like mood disorders really are like depression, episodic. So maybe all of a sudden they start getting worse, the depression comes in and they realize, oh, I've been suffering from an episodic mood disorder my whole life. I just haven't been subjective to it. A lot of times when people are depressed, they're like, I've been like this my whole life. And then they get better and they're like, I've been like, people we do a pretty good job at protecting ourselves from, I think it's a protective thing where we're like, from really looking at what the pattern has been. I think it's sort of a self-preservation thing, but it does kind of blind us to what, like, oh, it's really has been like this. And so, when you really have somebody like a therapist sort of open your eyes to it, you're like, oh, there has been a year of depression followed by a year of less depression. And so now I want to go get medicated for that, or I want to get treatment, or I want to get hormones, or I want to go hire a personal trainer because I realize that exercise has never helped. I've never benefited from exercise. I've done it for 10 years. I've never benefited. And then they're like, well, what has your pattern really been? Oh, there's been no consistency. And really, when I do look back at it, it has helped. But me exercising daily for a month hasn't helped for that 6 months when I was shot at it. You know what I mean? So now I'm going to go get a personal trainer. You know what I mean? So the therapists sort of open their eyes to it, and then they do want to pay for interventions, or they do want to invest in interventions.
Gotcha. Something that I frequently talk with people about, and it seems to be a big struggle amongst most, is sleep. People seem to either have a big difficulty falling asleep, or if they can fall asleep, they wake up multiple times throughout the night. And so that just kind of sets up, the next day for kind of poor energy, poor mood. And if they're just chronically sleep deprived day after day after day of poor sleep, do you have any decent, sleep hygiene tips, and then transition to maybe supplements and then prescription at that point? What has worked, what hasn't worked? I know that's a long question, but mainly sleep focused. Yeah.
Sleep is great. I love sleep because it's not easy to intervene, but usually you can get it. I can usually get it. You can usually be effective at it. There's usually enough things that can work, and usually can make a big difference. Like you said, usually it can make people feel better pretty quickly if I can get sleep resolved. And there is a really nice arc of like really low risk interventions that are effective. And then of course, the heaviest meds in the world are going to make you fall asleep. You know what I mean? So there's this great arc to it. Like you said, sleep hygiene is definitely the very beginning, where like, I fall asleep watching my phone. So there's no like judgment there. I'm not mad at you for doing that. I'm assuming every one of my patients falls asleep TikToking, and I'm not mad at them for it, but it's terrible sleep hygiene. It's not making you sleep better. So there's a good place to start. You know what I mean? I drink coffee at 5, 6, 7 p.m. all the time. Again, I'm not mad at you for it, but I do it. You know what I mean? So, but if you want better sleep, you should probably stop. When are you exercising? What is your routine? And I have a lot of patients who struggle with sleep and have really good sleep hygiene. So a lot of people are really, really willing to invest in good sleep hygiene and stick to it. So sleep hygiene is great, avoiding screens and all that, and having a routine. And when you're in bed and you're not sleeping, get up. A lot of people just sit there and torture themselves for hours on end. That's awful. Get up. You got to get up. You got to walk around. Go read a book. Don't say go eat something. Go eat celery or something. I don't know. Go be. It sucks. I can't read at 3 a.m. I don't know what to do. Just go putt around and then try to lay back down a half hour later, because you're just going to, you're going to associate that with stress. People are really stressed about it. After sleep hygiene, the next best thing is sleep restriction. People finally fall asleep and then they let themselves sleep the amount of time they need. So they go to bed at 10, they fall asleep at 1, and then they sleep till 10 again. You know what I mean? And then they try to go to 10 again, and then they haven't been awake long enough. And so where they up and down, and they get enough sleep over 12, 13 hours, and they just aren't up enough. So sleep restriction is the next best thing, where you only allow yourself, you find out how much sleep you're getting, and then you only allow yourself to be in bed that period of time. So go to bed at 10, and if you like, I've only been sleeping 5 hours. I've only been sleeping 5 to 6 hours a night. So 6 hours a night. You go to bed at 10, and you wake up at 4. And well, it took me to 2 o'clock to go to sleep. You wake yourself up at 4. You're going to feel like crap that rest of the day, but you're going to fall asleep at 10 that day, right? Maybe it takes you a couple of days, but eventually you'll start falling asleep when you want to. And then you start giving yourself 15 minutes to a half hour to that time. And that's CBT. When I say CBT is science evidence-based effective for insomnia, really it's sleep restriction, the sleep restriction component of CBT that is evidence-based. And sleep restriction is very effective if people can stick to it. And the more painful it is, the more it works. So sleep restriction is very effective. Also ruling out what might be going on, right? So like I deal with treating nightmares is seems to be like sometimes half of what I do. And nightmares is something that I'm very happy to jump to meds, because meds are very effective for that, and nightmares are just awful. So like progesterone for that can be very effective. But also there's like dream rehearsal, which I'm not sure if I've actually ever walked anybody through, but if I was a therapist, I would. I think I've talked to people about it. So like people who have recurrent dreams, like trauma dreams, you can rehearse them and you can journal them, and then so that way you can like change them eventually. So instead of them going the same way, you can kind of change them at night. So when you have them, they end up going a different direction, so they're not as haunting. So I think that's cool, and it's evidence-based as well. But progesterone can be so effective to just give them the relief that they need. Things that are so once you sort of if you want to break into supplements for sleep, melatonin is the most popular one. Did you ever do the WorldLink trainings with Neil Rosier?
Right. Yeah, I did. Yeah.
Neil Rosier said I take 50 milligrams of melatonin every night, except when I fly overseas, then I take 100 milligrams. Like that is wild. That is wild. And that definitely changed. Like I've never had anybody take 50. I've never recommended that, but it definitely made me a little less afraid of melatonin. So I've let people climb, because it's like Rosarum, which is like essentially like giving somebody 7 times the amount of melatonin we have been letting them take. You look at the guidelines, it's like, make sure it's 1 to 3 and no more. And I was like, 1 to 3? Like, get out of here. You know what I mean? Like, so I've had people eventually recover at like 15, 20. You know what I mean? So if people want to get, I don't know who this is for. This is probably for patients. So if you don't go, I'm not recommending patients go 20 on their own, talk to your provider, but things like magnesium, I give my kids magnesium. It's fabulous, and then
my favorite right now is magnesium L-threonate. Makes me dream good dreams. And like I wake up like I just went on a trip every night. And it's honestly my favorite supplement at this time. It's magnesium L3.
Awesome. Yeah, that's cool. I want to try that. But there's a bunch of them. So sleep, and there's a lot of them that help with sleep, and then like the meds that like trazodone has shown to improve sleep cycles. I think whereas like zolpidem and stuff like that seem to decrease the quality of sleep, but like improve the amount of sleep by like 15 minutes or 30 minutes. So not like much better, but sleep is so important that a lot of times you can outweigh the risk of long-term sleep med use. But usually I can get trazodone to work. The people tend to underdose trazodone. I can usually get trazodone to work. Most people can't tolerate the side effects, which most people can.
Yeah, I like trazodone a lot. I mean, that's the only one that I'll honestly prescribe. I try this supplement, sleep hygiene, and then if that's ineffective, I'll use trazodone. Has antidepressant effects, sleep architecture improves, and so it's but really, if I'm getting over like 150 and they're still struggling, then I'll kind of send them off, because I won't do Ambien or any other hypnotics. Just because I don't, they're the dependence, and I just don't do that enough to want to prescribe those kind of meds for them and everything.
I wouldn't advise it either, but I would say I go up to 300 pretty comfortably on trazodone. I don't sweat 300. I don't start them off. What I'll do is I'll do like 50 milligrams. I tell them to we don't, if it's too much, take a half tablet. I mean, a lot of people on a half tablet. So you can essentially say go up to 150 gradually, if and you can take half, so take it 2.5, because it does a really good job at if it's too much, it has a really good dose related. So the more is more sedating. So if it's too sedating, cut back a little bit, and you won't be tired in the morning. But I'll go up to 300 pretty decently. It seems it's nice because doesn't cause weight gain. It does, it may cause a little bit of dizziness. It does seem to have a little bit of alpha agonism to it. The biggest risk is not the biggest risk, but the biggest, not the most common risk, but the biggest concern is the priapism, which is like the prolonged painful erection. And so you just got to tell guys that. Yeah.
We called it trazodone in the ER. Yeah. I only saw it a couple of times, so it is rare, but I do, it's like, it is a possible thing that I've seen, so.
Yeah. As long as they know about it, and it's not going to happen. It's not going to be in a medical emergency the next day. It's going to gradually happen. People just don't want to talk about it. And so you just kind of say, if it happens, you probably should be taking them either that med or that dose. And tell me. And of course, give them the parameters of an emergency so they can go get it taken care of. But
sure.
Yeah.
A population that I talk with a lot is kind of going back just to lifestyle real quick, but I was in the emergency department for about a decade, and I interact with, ER nurses, police, firemen, that kind of population that's real high stress. I don't know if we ever, and maybe it's better now or anything, but nobody ever checked on my mental health. But at the same notion, I never checked on anyone else's specifically is things, you have a patient die, I had a preceptee, one time. It was like, well, what do we do now? It's like, well, we got a trauma coming, so we got to move them out of the way to make room for trauma. And, it's like, really, I feel that I've handled it well and everything, but do you have any tips for just people in those high stress, constant situations to at least check in with themselves? Or when do you finally think that you seek help or anything like that? Just any tips for those kind of populations of people?
Yeah. And maybe I'll kind of answer a different question so I can kind of get to it. I think of myself as I know that I can't do this job forever. And I feel like there's a certain amount of patients I can see. There's a number. There's a number out there in the universe of the amount of patients I can see. And I don't know what that number is. And it could be really high, but I know it's a certain amount of numbers. And as soon as I get it, I'm done. You know what I mean? And of course, hopefully I can retire, but I want to preserve that number and I want to preserve myself so I can take care of my family and stuff. So I'm always sort of mindful of that. And so that's kind of how I would look at it. And I think working with people with mental illness, and I think, the fact that there is a stressful element to it. I think maybe in any healthcare environment, there's a stressful element to it. So there is vicarious trauma, and then people who when you're resuscitating somebody and they die, that's real trauma. When you're witnessing death in an ER or in an ambulance, that is, you can literally be diagnosed with PTSD from that. That's in the DSM-5. So when you're exposed to that potential trauma, you are, I would have that in my mindset, there's only so much of this I could do. Now, maybe you could do that, to you're 100 years old and maybe your number's 1 million, but you don't really know. And so I sort of would keep it in, I would sort of think of it as I need to be able to take care of my family. I need to be able to keep my job, or at least have, another plan. So I think checking in with yourself, or having, if I was exposed to real trauma, like losing patients in front of me, I probably would be sort of saying a trauma therapist, you know what I mean? Or I would be having a professional kind of talking to me and looking into that, or being assessed. Because I would be, on even a practical level, I'd be I'm worried that I will get PTSD. I would be worried about that, or I would be worried that I would be able to do this long term. I remember I saw a patient. It wasn't my patient. It was when I was still a student, but he was a paramedic his whole life. He worked overtime. There were 60-hour weeks, and then he eventually retired, at a retirement age. And then as soon as he was done, he got severe PTSD and couldn't leave his house. It was almost the moment he was no longer exposed to the trauma, he was just like, he couldn't live a life anymore. You know what I mean? Like, it was like, it's almost like it waited until it was away from it. And that's kind of what I would be afraid of happening. And so I think because of that, I would sort of keep my fingers on a pulse of some kind. So I don't have like a specific, you
Okay.
should be doing this or that. I think everyone,
Sure.
but
Yeah.
I definitely I've seen healthcare providers like sacrificing themselves for the job. I was like, this job sucks. You know what I mean? So don't sacrifice yourself for this organization that does not care about you. You know what I mean? Like, this state
Yeah.
hospital does not care about your well-being. You do not need to sacrifice your health, your mental health, and your family for this, $28 an hour job. Like take care of yourself first. And that's sort of what I would say, whatever that means. You know what I mean? Take care of yourself first.
Cool. Awesome. Thanks for that insight. I think that was really good.
Yeah.
So now I kind of want to talk about hormones and stuff along with mental health. Like, I went to this conference that Dr. Morgenthaler put on. He's like kind of the godfather of testosterone, and helped us show that, testosterone is not causing prostate cancer and all this good stuff in the testosterone world. But while I was there, I sat with the psychiatrist at lunch, and I was like, what are you doing here? Or like, what made you come to, this conference? He's out of state and everything. And he's like, well, I've been working with a lot of people, and over the last couple of years, I've had more and more guys get on testosterone, and then I lose them to care, meaning that they seem to be getting much better mentally. And so I just kind of wanted to get more information for myself from a testosterone standpoint. So, I'm kind of biased, obviously, with, with the practice I have, that I think hormones are amazing to be a part of a mental health thing. What are your thoughts on hormones, and do you have any experience with them in your practice?
Yeah. I think hormones are fabulous. I think that, if anybody's wanting to I think hormones outperform almost anything with mental health. And I think if anyone's looking for a natural intervention or any intervention for mental health, hormones would be a great place to start. I think, um, I think honestly, hormones are kind of I don't even think it's one thing. I think hormones should be kind of all of it. You know what I mean? And I can elaborate on that in a second. And also, I think it's kind of expensive. So I think that's probably one thing that kind of deters people. Like, especially in my area, it seems to be an insurance world, and there isn't a good way to get insurance to cover hormones. And maybe we don't even want there to be. I mean, we probably want there to be, but we need. It's sort of limiting, and maybe that's a bigger conversation. But what I would say, so my experience with hormones, I did the World League trainings. I did with Neil Rosier, which just loved. It was fabulous, and I thought maybe I would incorporate hormones. And as a psych nurse practitioner, I wasn't sure exactly. Like, I think now, like, I definitely, with the trainings I did, I can definitely justify scope of practice. But what I struggled with is that I don't think there's a good way that I could have done it with an insurance practice and doing hormones. So it just isn't a really good way to do it. There's some exceptions that I still use. Like, I think thyroid is a good exception. And so, but as far as like, if I'm looking at wanting to feel better mentally, testosterone, I mean, like, it's one of those things. Is like, if I run someone's testosterone and thyroid as like a guy, like in their mid 30s or 40s, I can almost predict what it's at, and it's always crappy. You know what I mean? So it's like I can always, like, every guy in their 30s, in their late 30s, are coming to see me, and they're feeling a certain way. I'm like, I know what your thyroid is, and I know what your testosterone's at, and so it's like, I don't know, like, you get, it's kind of like this hormone, and that's why I think it's like, I don't know how insurance could even work, because it's not even a mentality of like, you're not even treating illness anymore. It's like, it almost feels like the heart of hormone replacement is everyone should just be honest. And I know there's exceptions to that, and I'm not trying to make a big political statement with that, but like, it's like, unless I have a guy in his, I don't remember how old he is, but he's maybe 50s or 60s, and his testosterone's high. I mean, he's got a good testosterone. Good for him. I don't think he should be on testosterone. But for the most part, people in their 50s or 60s, or even in late 30s, their testosterone's like 200, 300, 400. They should go on testosterone. They're going to feel really good. You know what I mean? And they're going to feel mentally great. A great example, like women, when they go through perimenopause and menopause, like, they lose estrogen and progesterone. It's gone. Of course they should be on estrogen and progesterone. Of course they should be on it. Like, it makes so much sense to go through depression. I don't know. So I think that I think it just is I think it plays a huge role in a lot of mental health. In pathophysiology, especially with estrogen and progesterone, can play a huge role, like with PMDD or the perimenopause, so I know that was super unelegant. I'm not really sure how to say. I think it plays a huge role. I think that
Yeah.
people feel a lot better on it. So I think, in a weird way, I feel like almost out of all the hormones, testosterone maybe is the maybe the least impressive that I've seen in men. Because the reason maybe that is because I think testosterone is so core to like guys that it's not even like, maybe just people maybe don't even feel better than maybe they just feel like normal maybe. So I haven't seen, and maybe I haven't seen enough guys. Like like maybe I've seen like 5 or 6 or maybe 15 guys versus hundreds get good TRT done. Um, but like, but whereas I've seen like estrogen and progesterone and thyroid just turn people around. You know what I mean? And I think also think testosterone is more of a longer term game. So I still think it's fabulous. I still think it's fabulous. So.
Yeah, progesterone, like I like progesterone's so good for females, like in terms of sleep. Like it's so nice. It's like they just start taking this at night and they're like, oh my gosh, I can sleep again. And then that can help alone, but then you start, touching, I'll do testosterone for females as well, but it's just such a, minuscule dose that, that gives them a little bit more energy, clears up from brain fog, improves libido, which may have been a, marital factor. And so a lot of times that can start a positive snowball or exercise, that kind of stuff. And so kind of transitioning to like so we've kind of talked about lifestyle and then hormones and I think they all are great in optimizing the vast majority of people, but that's not going to be everything. So, and because you are, psych, and I don't get to talk about it much, but I do want to touch on the various psych medications. Like honestly, just following on TikTok, I've learned more about psych meds than I have ever. Yeah, it's been awesome. Sweet. Just because I just never even had any lecture. I mean, so my background is ER and urgent care. So ER, they come in suicidal. We do, medical screening, make sure they're okay. And then they get placement, or if they attempted suicide, then we have to, resuscitate them, and then they admitted to the hospital. So I almost never did an outpatient psych meds from the ER. I went to urgent care, and I just really wouldn't do much. Like, honestly, I would do some hydroxyzine, PRN, anxiety, and maybe start like half a deal of Zoloft and maybe make them, and then I'd send them to, for psych follow-up, recommend counseling. But that is my really algorithm for myself. I don't have that deep understanding of this or that, going switching and when not. And like now, actually, I'd probably do a touch of Wellbutrin first, just because it doesn't have the sexual side effects. But God, I'm getting way off.
But like a hormone clinic, Wellbutrin may be a good, or like a weight loss stuff too. Like Wellbutrin's just kind of nice. You know what I mean? It's not. It's like it's like, I know it's pharmacology, but it's kind of nice. You know what I mean? To throw that in there, so you might find some mileage amongst your clients. They might be appreciative of a little bit of Wellbutrin here and there. I wouldn't do Zoloft for your clients, but
yeah. And so how do you, like, somebody comes to you and, how are you going through med choices, med management in your head? I mean, I know there's just a million. Have they been on meds in the past? Have they worked? Have they not? But how do you just kind of start from a nurse practitioner standpoint in psych? Somebody comes to you, how do you start your assessment of them and when to start meds or whatnot?
Yeah, it's definitely very multifaceted. You're always sort of surprised when someone comes and starts talking to you. You're like, okay, where's this going? And and it just has a lot to do with where they've been, where they're going, what they've been on, what they haven't been on, and a lot of it, where they, like I said, and I sometimes have to remind myself of my roots of not really, understanding the limitations of medications and wanting to prioritize lifestyle, and there was a big period of time where I wasn't even bringing it up, and now, and then I actually am feeling like I should, and I'm doing more. So I guess going. there's a couple of you're wanting to balance the risks and benefits of medications, and maybe we do that a little bit too much with trying to avoid side effects. And I think people tend to stay on medications better if they work. And I think we make a mistake in giving people medications because they're more tolerable rather than more effective. And I think really what the studies show is that people tend to stay on medications. They said stay on medications that are more effective, and get off medications that are less effective despite side effects. But the things like for depression, um, the Lexapro and sertraline and Wellbutrin, that's the Harvard first line, Harvard algorithm first line for depression. And so there's nothing wrong with that. And when somebody comes in and hasn't been on anything, there's a really good chance that's going to work. You know what I mean? It's when somebody hasn't ever not been on the medication. But also there might be a chance that something like L-methylfolate will work too, because people tend to respond really, so you do have this sort of, oh, you haven't been on anything before, there's a good chance that the first thing's going to work. And even when people have been on one thing before, there's a really good chance that the second thing's going to work too. Once you get into sort of that third thing, then you sort of get sketchy, but you can kind of go back in time and say, well, tell me what those first couple trials are like. Because sometimes they were like, well, I was on Prozac for 6 months. Okay, what dose are you on? I was on 10 milligrams. The whole 6 months? Like, yeah, okay. Well, that wasn't really a trial. You didn't really try the net. You tried, a subtherapeutic dose or maybe the beginning dose for a long time and never really gave it a trial. So there's still a good chance that person would respond to a higher dose of Prozac. And so, but once you get to somebody who hasn't tried, who has tried several antidepressants and given up good trials, you do want to, you sort of want to stop screwing around with that kind of medication like the SSRI and start offering them medications that are going to be really effective. Like I love lithium. Lithium is very effective. The antipsychotic medications have a lot of risks, but they are more effective. Ketamine is very effective. Esketamine is very effective. The older antidepressants, the tricyclics are very effective. So there's a lot of meds that are really effective that have a lot of risks and side effects. But it's kind of like with side effects, it's kind of like you either get the side effects or you don't. And if the side effects happen and they suck, you can stop the med and they go away. You know what I mean? And then the long-term risks, when we talk about long-term risks of medications, the only reasons we're dealing with the long-term risks is because the med has made a significant difference and it's worth it. You know what I mean? And usually we can kind of mitigate that. The antipsychotics are a little bit harder because the long-term risks are like movement disorders and like metabolic syndrome, which feel a little bit more permanent. Whereas like lithium, the long-term risks are like kidney dysfunction, which is reversible and very easy to monitor. So I don't know, that kind of answers your question. I think my point is more like, wanting to use and prioritize things that are very effective rather than things that are perceivably tolerable.
Yeah. And how do you, it's, again, just the SNRIs, SSRIs, and the other starting ones. How do you decide which one? I mean, you have some background experience where you've probably seen and tried every one of them. Like I said, I tried sertraline and sent them away. So I don't even know how it actually works. How do you know, like, which one to even start with or anything?
Yeah. So just among the SSRIs, there are very subtle pros and cons. There's not enough difference amongst them to really lose sleep over. Sertraline might have some dopamine promotion. That's kind of cool, right? We're all kind of, that's kind of cool. Prozac has a really long half-life, so you don't get the serotonin withdrawal effect or discontinuation effect. That's great for teenagers, right? If they'll want to take their med every day, we're going to forget it. Sertraline, you could probably miss 2 doses. Sertraline's like about halfway in between sexual dysfunction, so it's not great with sexual dysfunction. Prozac's kind of like not neutral, but not too far. Paxil's the worst. Celexa, Lexapro are kind of over here with Prozac. Celexa is I probably never started anyone Celexa. I probably never started anyone on Paxil. I've continued people on them who've come to me on them. Celexa is just Celexa was modified into Lexapro. Lexapro is like a cleaner version of Celexa, and it just works better. So Lexapro is just it's the purest serotonin effect you can get. So I tend to start people on Lexapro first line all the time. It's pretty good. Although Paxil probably is the most effective anti-anxiety of them all. Not significantly, but it is more effective. It is the worst as far as side effects. It is the worst as far as sexual side effects. So there's no reason probably to use it at all. If you're on it and it works, there's really not a diss to that. I do that on the TikTok page. Be like, oh my gosh, I'm on this. Should I come off of it? No, unless you want to. I don't know. Talk to your doctor. You know what I mean? So the discontinuation, Paxil is probably the worst because you can like miss a dose and you start having the discontinuation. Prozac's the best. The medications are effective after like 5 half-lives. You really want to get like 5 half-lives steady state, which is why it takes 6 weeks to sort of work. So that makes Prozac hypothetically take another 2 weeks to work. So it's probably why Prozac isn't considered first line. On a clinically, I have not seen that be the case. Prozac does not seem to take longer to work. Because when you're talking about people and how complicated we are and how much placebo works, responders tend to respond and non-responders tend to not respond. That's more the reality than what meds work. People tend to respond and non-responders tend to not respond. And then the effectiveness of the medications tend to take over after that. Does that make sense?
Gotcha. So kind of a little different. Instead of depression, anxiety, focus. I mean, I feel like with social media and everything, we all have some sort of ADD component, whether, diagnosed or not, probably. Yeah. Like I probably just high dose caffeine myself to get some stuff done. Maybe I need more than that. I don't know. But do you have any like focus tips on how to manage focus and that kind of stuff, med or not? Or are meds just truly the most effective and consider meds at that point?
Yeah. I think there's a lot of environmental modification things we can do, a lot of acceptance things. I think that, there's a combination of relating to each other a lot. This is what sort of fueled, I think, the ADHD craze, which is a good thing. It's good that we're relating to each other, right? And I think, it's also, also our worlds are becoming, COVID sort of made our worlds sort of small like this. We're not, we're all sort of working like this. And so it's hard. I think we kind of feel off by all having to sort of work like this. So medications can help. But I think there's a lot of sort of doing what you have to sort of make it work for you. I definitely, ADHD is my bias. I mean, I worked at a state hospital for 6 years before I went to private practice, and I didn't see anyone with ADHD. Maybe I saw like 1 or 2, but no one gets hospitalized for ADHD. So I saw all this psychosis. I saw all this mania. I didn't even see a lot of, just depression. I saw all of this, and you go to private practice and it's all depression and ADHD. And I was just not like, and it was such it was, I've gotten better at it now, but, and then after COVID, it was now if my private practice was open right now, it's only open for people who want to do TMS and esketamine. If it was open, 2 out of 3 intakes would want ADHD treatment. And I think that's just being fueled by, like I said, people relating to each other and the lifestyle. And so recommendations, what I hear people talking about their symptoms is like, oh, you're relating to each other. And I think it's just a lot of it, like, I think normalizing that that's how when people tell me stuff, I'm like, that's how I feel. That's how I feel. You know what I mean? Like, I feel the same way. Like, that's how we all feel. That's you know what I mean? And so I don't know why it's sort of, we're relating to each other at the same time as we're making them, you know what I'm saying? Making it like a disorder at the same time.
It's not all pathology.
Yeah, not all pathology, but it's like we're all the same, but it's all disease. We're all diseased together.
Nice.
And so we shouldn't be on stimulants, or we should, because we're all on caffeine. We all smoke weed. I don't smoke weed, but we all smoke weed. I assume everyone's smoking weed at least. We're all smoking weed. We're all drinking energy drinks. We're all drinking coffee, right? And so just, I don't know, I just am tired of being a gatekeeper. I'm whining now. This is me whining about it.
That's like,
Uh,
weed's legal in Washington, right? It's not
legally.
legal here. So
Oh yeah, you're in Texas.
we,
You guys are so.
yeah,
And
yeah,
everyone,
we're not quite there yet.
yeah, yeah. I was like, it's like, you smoke weed? It's like, yeah. It's like, did I smoke weed? Did I smoke weed this morning? Is that what you're asking? Did I smoke weed before I got in the car before I got here? What are you asking me? Did I smoke? Of course I smoked. Um, and it's like, well, that could, you know what would help with your focus if you did smoke weed on the car to your job? That would help with your focus. But I think, yeah, I think there's a lot. I think it's just a lot of acceptance of just like the fact that we're not designed to sit at a computer all day, and it's okay that we need to get up or walk around or interact or you know. I yeah, I don't know. That wasn't a real answer, but I love that conversation.
Yeah, yeah. I mean, I've seen like modafinil used.
Yeah.
I mean, mainly for again the ER shift workers. They're doing it, but then they report they feel a lot better focused on it. Do you ever use that for focus specifically or anything?
Yeah. Oh yeah. Modafinil is hard to get approved by insurance. It's nice that it's under control too. It's not that hard to get approved by insurance. It doesn't probably work as well for ADHD than the ADHD meds, even though the studies show that it's non-inferior. It probably is non-inferior when you're really breaking down. It's like ADHD meds are not these magical pills. And what I notice in people who don't really have mood disorders is that the ADHD meds are great. They're fabulous, and they make a huge difference. When they have like this ADHD, symptoms and are really struggling, they don't really have mood disorders. They tend to come away from these ADHD meds and just doing fabulous. When they have mood disorders, what ends up happening is the mood symptoms come up and down because it's really hard to manage them, especially with ADHD. And so the ADHD meds work, and then the mood symptoms happen, and then it feels like, oh, the ADHD meds don't work anymore, and they've never worked. I was like, well, they did work. You know what I mean? So you have to, you sort of lose perspective a little bit. And or someone will be like, because I think the biggest reason is because inattentiveness, the concentration issue, is very painful. It's one of the most painful issues or symptoms of depression, and it's the more subjective symptom than sadness. People don't really perceive the sadness. Sadness is not a good subjective symptom of depression. It's not describable. People don't say, I'm just feeling really bummed and sad all day. That's really not what happens when someone's depressed. They have low motivation. They feel really tired. They don't find anything interesting or pleasurable, and they can't get stuff done. And so the concentration is what they really perceive, and so that's what they're really finding, and they want. And so what I find is that the meds are really a lot to be desired when somebody has those issues, and so it kind of becomes this sort of discouraging cycle with those treatments. So I feel like I'm negotiating with patients about, well, let's try, these medications, and they're like, no, I'm not depressed, So I think I do a good job in the conversation. It is a little bit more work and effort to sort of, because I don't want the patient to feel, I'm coming across as cynical, but I don't want the patient to feel that I'm not listening to them. I'm not hearing them. I want them to feel heard. I want them to feel listened to. And at the end of the conversation, I want them to feel like on board with the plan and that they're doing something that's going to help them. And I think I do a good job of that.
Nice.
Yeah.
So you touched on it a couple times, but when do you bring in ketamine, esketamine, TMS, those kind of treatments? When are those part of a patient's plan?
It's so people will seek us out. So it tends to be, so we're like, we're even on Google as Ketamine Clinic. And so people will, go on our website, and we have sort of a questionnaire for them to see if they could be a good candidate based off insurance policies and really what's the FDA on labeling is for. And it really just has to do with diagnosis of being major depressive disorder, and if they've trialed several antidepressants, sometimes mood stabilizers, or like adjunctive medications, and then they can become a new client. So really, for us, it's pretty much all of our new patients, because that's what we're kind of open for. That's kind of what we became as an Ketamine.
Sure.
My time is spent mostly with medication management because that's what I had been doing previously. And then as I hired people and we grew, we became an Ketamine client. So I do the intakes for them, and then the team sort of takes over. And a lot of my time is spent doing that as well. It's kind of split. But so if somebody hasn't responded to 2 or more antidepressants, then they can be a candidate for esketamine, depending on their insurance. and if they haven't, they're not pregnant, they're not using drugs and stuff like that.
Sure. What is TMS? Is that a chair that is decommissioned, killing people or whatever? Is it a little shock thing? And when do
Yeah,
you do that part of a treatment?
it has a little magnet, and it sits on the back of their head, and it just sort of the front of their here. It is, and it stimulates the brain, and it's just a little uses a magnet so it can get through the skull without being too painful. And it's just a little bit of stimulation. You do it every day, and I think because you do it every day for like 36 treatments, it sort of builds up, and then it sort of lasts a long time. When they did like electroconvulsive therapy or the ECT, I mean, they cause a seizure in the person, like that, they have to use all that electricity because they can't get through the skull, right? It's all going to come over their scalp, and it's too painful, so they have to be anesthetized. But the magnet allows it to get through the skull, but it's not very far into the skull, and so you're kind of counting on the brain to take the stimulation and sort of and kind of use it downstream, and I think you're sort of asking the brain to sort of respond to it, right? When ECT causes a seizure, not what we're using, but the ECT now when it causes a seizure, and you're asking the body to fight the seizure, and it's doing so, I think it's very protective and causes a long-lasting effect. Now TMS is much milder, but I think you are asking the brain to respond and potentially
And
protect.
what is happening? How do you get a positive benefit out of it?
Yeah, I think that there's a lot that there's just a specific spot, and that spot gets stimulated, and that causes this cascade of events. And if that doesn't happen, it doesn't work. And I think that's not the case. I think it's much more diffuse and unknown. I think it was sort of I'm not random. I think they were well educated as far as where they did with what. But even now, they're like, yeah, they did it this way. It was sort of arbitrary. I think there's a lot unknown about why and how it works. But and someone's gonna watch this and like, no, it's wrong because all this stuff happens. I'm sure there's a lot of stuff that happens that they know about, but like it is, like you said, I think you're sort of asking the brain to respond and to sort of interact with what's going on. And it creates this downstream effect that, creates neuronal plasticity, new neuronal pathways. It creates, neurotransmitters to be released, so it has a sort of long-term effect. And really, out of all the treatments that I know of, is the only thing that seems to have a long-lasting effect that doesn't require ongoing treatments. So it seems to like, when you're done with treatment, it seems like it lasts up to a year when it works, which is pretty cool.
Nice. I like reading about. Oh, sorry. I like reading about all the psych meds, and they're all like, yeah, we don't know how it works, but it does. That's still the thing for a lot of the psych meds today.
Yeah. They like to tell stories, and I always am so cynical, and I need to do a better job at learning about how they work and stuff. But it's always like, I know this is just a story. I know it does 20 other things that they're not telling you because they don't really know. You know what I mean? Like there's always so much more complicated than that. But they tell a nice little story about the neurotransmitter and the serotonin modulator and you know what I mean, the regulator, and it paints a nice little picture. But it's a little bit disrespectful to how complex mental health is and how little we know about it.
Right. What about like emergent treatments like psilocybin, MDMA, people going to whatever island and smoking ayahuasca or whatever? Is any of that maybe going to come mainstream, or is that all just kind of hogwash social media stuff?
I'll comment briefly on it, and then we should do a podcast on it. I can do a full hour on psychedelics.
Oh man, I would love that. Yeah, we
should schedule that up.
Set that up.
Because I touched on that because when we met at the Elite NP, I did a little bit of section on it. Because they did they tried FDA tried to get the MDMA approved, or they did. FDA didn't try, but they with the pharmaceutical company. No, it's not a pharmaceutical company. I don't know what they are. They're like a nonprofit. Tried to get the FDA to approve an MDMA, and there's quite a few issues with that. But see, who's just going into DMT, and something just went into phase 3 trials for generalized anxiety disorder. Psilocybin is still in phase 2 for treatment-resistant depression, and then they're doing another phase 3 for MDMA for PTSD, and I just don't know enough to predict, as to whether or not they will see the light. I think there's enough interest. I mean, like even when the FDA was had already received the recommendation to deny the MDMA by their, their board of whatever the experts, which they usually follow, senators began to reach out and said, you got to approve this. So there's already sort of the government is coming out and saying you should approve. You know what I mean? So they already have support in areas where they would fear pushback. You know what I mean? You know what I mean? So like the FDA, whoever the FDA is afraid of, I think they're sort of losing that sort of excuse. So I think the FDA is getting to the point where they can sort of say, okay, we'll approve it and not be worried that XYZ will come out. And maybe, and so I think something will get approved soon, in the next 5 years. And that'll be cool. That'll be mainstream.
Nice.
That'll be insurance approved and people can get it. And that'll be cool.
Nice.
Yeah. I'll be all over
So I was nearing in on an hour, so we'll kind of close up. Just say somebody who's kind of struggling mental health wise, doesn't know where to go, doesn't know who to talk to, what to do. Do you have any tips on just how to navigate that person to the appropriate steps in addressing their mental health?
Yeah, I mean, I think one of the hardest things that I see people are struggling is it's just a phone call to try to talk to somebody, and then I'm taking clients, and then it just becomes this cycle of like they feeling shut down. Like I get that it's just really difficult, and then you get 2 or 3 of those phone calls, and then you just can't do it anymore. So so I mean, it's just doing your best and doing what you can and being honest with yourself and trying again when you can try again. Websites like Psychology Today will let you type in your insurance. Don't Google things. Don't go to Google and say therapist Melina and click enter and then call that. I had all people call and say, hey, do you take this insurance? I'm like, no. And they said, well, I Googled you and it said it did. Well, if you Googled psych and then you Googled your insurance and I came up and you assume that meant I took it. So if you go to Psychology Today, you can actually screen out, that's probably better than even doing it on your insurance website because your insurance website might be outdated. And you can find a therapist that way. You can find or a psych nurse practitioner or a psychiatrist, and that would where I'd reach out to, or find somebody who knows somebody and get a recommendation that way. But that might, and then you can reach out via email via Psychology Today. That way, people who struggle with the phone call, at least, but don't be discouraged if you don't get, phone calls still might be better, but that way you can, send a dozen emails and get 3 back. Yeah.
Psych access here where we are in kind of West Texas is pretty difficult to get in with anybody ever. Yeah. Do the online platforms, do they offer decent things to at least get started in the interim? Are those effective or what are your thoughts on that?
Like I see a lot of people all over Washington State. And so as long as people are willing to be virtual, I know Texas, has some restriction for psych nurse practitioners. So you might not have a lot of psych nurse practitioners who are, remoting in. But yeah, if you're willing to see somebody virtually, there's a good chance you can see a therapist or a psychiatrist virtually. They may not be in your state, but they might be willing to see you.
Are you only in Washington? Do you have any other licenses? Okay. Well, thanks for meeting with me. If people want to follow you or get some more information from you, how can they find you?
Yeah, Goodwin Health Cafe on Facebook or Instagram, TikTok. I'm on Facebook probably the most, or TikTok. I'm on TikTok the most, to be honest. So you can email me, nick@goodwinhealthcafe.com. I'll respond to email. So yeah. Okay.
Well, cool. Thanks for meeting with me, and I very much appreciate your time and everything.
Yeah, man. Let's do the psychedelic podcast. Let me know. Let's schedule it. I'll do research on that one.
Yeah, that'll be fun. Yeah, for sure. All right, that was our podcast with Dr. Goodwin, the psychiatric mental health nurse practitioner. If you want us to do the psychedelic one, where we kind of go on more of the alternative treatments and more info with that, let us know. I am trying to do various topics of just health. We've done the resistance training. We're going to do one with kind of a lifelong athlete, to where we talk about health and being active forever. We're going to do one over running and how to get started running with that. If you have any other topics that are health related, hormone related, dermatology related, overall lifestyle related, or anything like that, or you have any questions about anything, of course, text our office number 325-777-0737 or shoot me an email at liveoaktestosterone@gmail.com. We'll see if we can get something rolling if you're specifically interested. Thanks.